Okay. Hello, everyone. Today I want to talk about this case, talking about Invisalign deep case, deep bite case, and class 2 division 2 case. So the last year, 2020, I will lecture on the YouTube, so the international attendees. But this time, many of the colleagues and many of the friends want to see the international version on the YouTube. And today I will share with my case about the class 2 division 2 for non-extraction approaching cases. So many of the type is a class 2 is there. Then some of the time is a class 2 is only very easy to idea the upper molar distalization. Some of the time is extraction. Many of the solution is there, but one of the solution, one of the approach is class 2 division 2 like this. This patient is a 43 years old female patient. Chief complaint is how can we treat for this patient AP correction, right? The Invisalign system, aligner treatment is some of the time is many of the doctors, many of the patients, many of the orthodontists. Idea is a very simple case only. So close, just a little bit, simple case. Arigato. Simple case, a simple crowding. But nowadays, so many of the doctors, many of the authors publish on the great article. Then so the Invisalign aligner is many of the possibility, the molar distalize. Then so my mentor, my master, Dr. Barnaship from the Germany, he already published on the Journal of Clinical Orthodontics, 2010. The name is Invisalign Treatment Class 2 Approaching. At this page, at this article is according to this article is molar is distalize is very possibility for the aligner treatment. Then we learn from him. Then after that, how can we do class 2 division 2 molar distalize? Okay. The molar distalization is some of the time is very difficult approaching because the molar is big and many of the root is there. Then so that some of the time need a mini screw, then control molar distalize more easy. But aligner is totally different. Why? Aligner is gripping the molar, gripping the crown, then hold all aspect, then slightly move completely very faster. Please have an image. Multi-bracket braces, lingual braces, only one aspect, labial side or lingual side. But the aligner is all surface, is gripping, then slightly more distance. That is amazing. This is the new approaching. Then the class 2 division 2 molar distance is simply planning or not. Please have a look. In this case of class 2 division 2, mandibular shift to the back from upper anterior teeth lingual inclination. Many of the class 2 division 2 case is like this situation. Upper anterior teeth is a very severe lingual inclination. Then so many of the time is a patient mandible is shift to the back. We have to check this point. This is very, very important thing. Clap, jam, Italy. Oh, ciao. So if class 2 division 1 patient, division 1, severe budget like this, no need to think about mandible is shift to the back, right? But the class 2 division 2, we have to think about position of mandible. Class 2 division 2 like this, then patient mandible shift to the back. How can we start this position? Is it the right or not? Very important thing, the position, initial position. Have a look. This is 僕の携帯。誰の？君の？音を消さないと。This is upper anterior incisors. Then lock to the mandible. Then mandible is a shift to the back. Many of the this patient is maybe have a problem to the joint because this situation. I will show you again because this is very important thing. Class 2 division 2 patient, anterior incisors shift to this lingual inclination. Then mandible will be almost shift to the back. How reaction this patient? Maybe I think problem is a joint, just creaking, some pain, some problem. If take a scanning this situation, then send to the Align technology. This is the right way or not? My opinion is no. My opinion is we have to check first initially, then where is the problem for this patient? Of course, anterior guide for the clouding is a problem, but a more big problem is position of mandible, position of condyle, right? The condyle position, mandibular position cannot understood in Invisalign ClinCheck simulation. So we have to think about everything. Orthodontists think about everything. The joint problem, position, guide, everything. Many of the doctors focus on only ClinCheck. The ClinCheck management is good, ClinCheck staging is good, but this is the part of aligner orthodontic. We have to think about everything because the patient is not only teeth. Patient have the pain, patient have muscle, patient have bone, patient have joint, right? Because initially we have to think about position of condyle, right? Then my decision is problem is here. Initially, how can we prevent this problem, right? The mandibular shift to the back, then will be disc is forward. This is the initially started to creaking, initially started problem. Very important thing, same as this. Teen patient, and some of the time expansion patient, class 2, division 2 is the same situation. Anterior, upper anterior incisors is a severe inclination like this, lingual inclination, every single patient. So we have to think about initially focus on the position of the mandible, right? Then this is a ClinCheck, right? As you can see here, same anterior teeth position. Every single patient is a different tooth position, guidance, tooth size, everything is different. But approach is almost focusing because how can we prevent this tooth angle? This is a very important thing. Initially, how can we approach it? This one. If class 2 division 1 patient, initially simply upper molar distalization or extraction canine, extraction first premolars. This is the normal approaching. But class 2 division 2 is totally different. Why? All these teeth is definitely lock the mandible. Take a scanning procedures, the patient teeth, then send to the Align technologies, then create ClinCheck program. This is okay or not? Already you understood this is not good because all these patients have to think about joint, anterior guidance, the position of the mandible. If without the mandible, without think about condyle position, only focus on clean check, maybe this treatment planning is not good. My master, Dr. Bernard Shoup, all the time talk about me. Please focus on initially functional analysis first. In my office, all patients come to my clinic. Initially, we have to check the condyle position. Then, if have a patient pain or norm, and the joint, guide, everything, before I create a clean check. I never do clean check first because our patient is a human being. Human have a muscle, human have a nerves, patient have a pain. If no pain, no functional problem, initially started to Invisalign planning, but almost like this situation is the mandible shift to the back. How can we transfer clean check? This is a very important thing. Have a look. Teen patient, upper molar distalization patient. This is an expansion patient. All aspect, we have very important thing. Initially, the focus on this axis. This axis is problem because this axis is mandibular will be back. Okay. My planning is what is a good solution. Please think about this. If class 2 patient come to your clinic, many of the doctors think about upper molar distalization. This is the planning one. Upper molar distalize, second molar distalization, first molar distalization. This is a sequential tooth movement. This is normally. This is traditional approaching for the class 2 patient. Then after that, canine retraction, finally anterior retraction. Is this good or not? This is the planning one. Molar distalize first. Okay? Just now, 2021 generation, clean check cannot change the joint, cannot change for the muscle. Only initial position transfer on the clean check. This is planning 2. Planning 2 is initial approach is not second upper molars. Planning 2 focus on initially upper anterior incisors. Have a look. Initial staging control anterior teeth. Like this. Proclination first. Easy to understood if you are planning upper anterior teeth proclination first. The patient mandible will be naturally forward. But this simulation cannot transfer the mandibular forward. But orthodontist and the doctor have to need image. Your clean check, how can alive your patient in the real tooth movement, real molars. My approach is this. I decide on planning 2. When initially patient upper anterior teeth is proclination first, after that naturally patient mandible is forward, shift to the forward. Here, initially, upper anterior teeth proclination first will be this position shift to the mandible like this. But this simulation cannot happen to on your PC, on your clean check, on your simulation. This is an image. Okay? This is the same as bracket system, same as ringer braces. Okay? So we have to the image. If you're planning the molar movement fast, or if you're planning anterior teeth move fast, how reaction your patient, the mandible, and the joint, everything. After that, focus on tooth movement. Okay? Initially, like this. Canine, the first molar, definitely class 2 situation. Okay? This is the class 2 situation. Upper anterior labial inclination, mandible will shift to the forward. This is not tooth movement. They just naturally forward to your patient mandible. We have to think about the function analysis first. If function anyhow a problem, you have to first approach is not to simulation only. Very important thing. That this is the patient is a human, not simulation, right? Then differentiation of position of molar and canine. Totally different. Then we have to check more precisely. Okay? Go to the patient photos. This is the patient initially. Chief complaint, deep bite, narrow arch, class 2, division 2. As you can see here, is a upper incisor is a definitely lingual inclination. Then lock the mandible. Okay? Then if you decide on normal approaching, upper molar distalization, maybe not good. How about look? And the very important thing, the patient, the facial analysis. Initial like this, not good smiling line, and the patient just a little bit back to the mandible, as you can see here. But the patient, the chief complaint is just a little bit upper anterior is just forward. Okay. This is X-ray. As you can see, here is a safe. Mandible just a little bit shift to the back. And this is a panoramic X-ray. Here is a wisdom tooth. Here, then my planning is extraction. Wisdom tooth here. And check the condyle position too. On MRI and some of the time CT. My planning is this. Initially, this is overjet. How can prevent? Already you know. Initially, like this. Proclination, then naturally forward to your patient mandible. Then after that, we have to think about how millimeter distalize is needed. Okay? I use this software. This software name is also communication. This is easy to compare to initially and today. This is the initial position. Have a look at this movie. This is the initially. Then this is a progress of treatment. Initially, as you can see here, anterior teeth is proclination. As you can see, lower mandible shift to the forward. Okay? Different. The canine position is already different. This is the class 2, molar side class 2. But this is already edge to edge, right? Then re-scanning again. Because already good for the axis for the upper anterior teeth. Then we have to check re-scanning again, then analysis, take a more treatment planning, then started to distalize upper molar. This is the real upper molar distalization account. Because the initial time is a mandible shift to the back, but this is already the good position to the mandible, then alignment. As you can see here, this is a refinement. Initially here, just slightly distalize, just slightly. Initial time, definitely class 2 situation canine and definitely class 2 the molar situation, but now different. Then started to treatment, extrusion and the control anterior guide. Then all the teeth is bite and good for the position and alignment for the upper arch here. If needed, just a little bit additional distalize But my planning in refinement, just a little bit expansion upper and lower arch. Alignment here. This is more distal, initial situation. Then started to anterior control first. Then initial situation. This is the initially. We have to control anterior axis first. This is my planning, already you know. This is a canine, and this is the first molar position. Definitely class 2 relationship. Upper and lower. Control upper anterior teeth axis and place on the attachment. Okay, attachment procedure is very, very important thing. Please, the watching our publish of the book. Okay, then this is same as this. Root control. The crown is proclination. Not molar distalization, only focus on anterior teeth. This is upper and the canine position, almost still there. Then just a little bit mandible is go to the forward, naturally. This is still continue upper anterior teeth is increase proclination. As you can see, just a little bit change the molar position and the canine position too. This is naturally. No need any other lower anterior teeth is forward and the molar medial movement. Naturally tooth movement. Then, as you can see, totally different upper anterior teeth is the axis. Then mandible shift to the forward. Then teeth position and the canine and the first molar is just different. As you can see here, this is the edge to edge. The first molar is almost just a little bit class 1 relationship. Then more started to the refinement, molar distalization phase. You can see here is achieved class 1 relationship. No need any other TAD, no need any other mulch braces, only simulation idea as the position patient for the joint. Then here is the final situation. Finally, we achieve anterior guide. The canine guidance is class 1. Class 1 relationship, the molar side, everything. No need any TAD, only alignment, elastic, planning, think about the joint, function, muscle only. Tooth alignment is done. Anterior guide is done, improved. The molar contact, everything is completely perfect, but the very important thing is smiling, because the patient, the focus and the main interesting is beautiful smile. This is progress. Initially attachment on, this is started to the anterior toe control, then class 2 shift to the class 1, molar distalization, this is the final situation. This all situation is aligners. ちょっと文様出ちゃってるから変えた方がいいと思うよ。こっちは大丈夫。This is a comparison initial and final. Initial and final, totally different. Not only AP correction. This is a vertical control, alignment, and the guide everything. Here is a initial and final, the class 2 position to the then this is the class 1 relationship. This is the left side. Left side is edge to edge for the occlusion, but finally is a definitely class 1 relationship. This is a very safe and good for the guidance, and the patient is more comfort position. This is the upper side. This is the lower side. All these treatment is using just aligners. Okay. This is the final situation. The midline is correct. No canting. This is the right side. The canine guidance achieved. No posterior open bite. All the tooth is bite is perfect. This is the upper side arch, lower side arch. This is the left side. Canine guidance is a class 1. Molar is a class 1 relationship. All the tooth is perfectly contact. This is the tooth. The tooth position is good. We have to check smiling. This is a smiling. We are using digital smile design. I am a key opinion leader at DSD and globally. Please have a look. This is a smiling. It's perfect because I check. Initially, I focus on which position is good for this patient. Smiling, the canine position, and the midline. This is initially I planning this position, then alignment. Have a look. This is a OPG and the cephalometrics. Tooth alignment is good. Comparison initial and final, front side and right side, and the smiling. This is a finally totally different. So many of the doctors, many of the orthodontists think about Invisalign system is only tooth. But my clinic, my approach is not only tooth. Occlusion, guidance, smiling, and long-term stabilities. That is very important thing. Initial and final, how can we change the mandible position? Initially, it shift to the back, but finally, the good smiling, good profile achieved. The tooth position is very important thing, but facial, smiling, and the bone situation, and you can see here is you can see compare its anterior positioning is very good. And this is very amazing. This is the airway. Airway is different. Here, initial position, the mandible shift to the back. Already airway is very narrow. But after orthodontic treatment, mandible shift to the forward, then airway is more wide. This is a change, the sweeping time, no apnea syndrome. Okay. Initial and final, the tooth position, joint, airway, and smiling, everything. This is aligner orthodontic potential. Very important thing, not only tooth alignment. This is retention 5 years. After end of the orthodontic treatment, this is a 5 years retention phase. Have a look. Midline is correct. Canine position is achieved. And the upper and lower is stable. This is 5 years retention. 5 years retention, smiling is still beautiful. Initial, final 5 years retention. Today is I already share my experience. This is the initial, final 5 years retention. This is the class 2, division 2, non-extraction approaching. Great, thanks. Invisalign mandibular advance is very complicated. Yes, maybe need to the change aligner extraction for mandibular advance. Yeah. The name is Benari. Thanks a lot for the watching my YouTube channel, Benari. So you are right for the very difficult to the positioning. For the initial position is a wrong or right. So the one solution is check your patient condyle position and check for the function, the movement, take movies. Some of the time, patient is a habitual occlusion is just a little bit back, then problem. Some of the time, patient don't realize. At this time, my recommendation is please use aqualizer. Aqualizer is using the patient just 1 week or 5 days. Then so this is aqua in this plastic. The patient sit in the mouth about 15 or 12 hours per day. The patient is a repositioning, so the new position. Some of the time, CO and CR is different. Some of the time, is your patient condyle just a little bit change. After that, take a scanning is more easy to create your patient clean check, or initial time is same as this patient. Initial clean check only focus on upper anterior teeth, then like this. After that, change for your patient mandible, then rescanning again, replanning is more predictable treatment planning and easy to control for the patient. Okay? 日本語版は出しますか？ミッケルさん。日本の方。日本語版もいいですよ。やりますよ。But, Benali, thanks a lot. So our team is, will publish like this YouTube channel for the internationally version. So please watching this channel, okay? So we have many of the contents, and just now is a very terrible situation for the globally COVID-19 is a situation. So I can do is using technology like this, then share to my experience. Please learn on the YouTube. Then please take care of your patient and take care of your family. Thanks a lot for watching for today's my YouTube channel. So that maybe I planning the next year will different for the topics. Thanks for watching. Bye bye. See you.